The next one will be about, the office. Dr. Guruparan will speak about evaluation of the patient with a high office blood pressure monitoring. So very, very everyday question, and I'm really looking forward to this presentation.
Good afternoon. I would first of all like to thank the Sri Lanka College of Cardiology and the European Society of Cardiology for giving me this opportunity to speak in this symposium. My topic today is evaluation of high office blood pressure. We know that hypertension is a common problem and it is the most common reason for office visits. And we don't have local data in Sri Lanka, but in India, one of the studies showed that 42% of Indians are either misdiagnosed or have missed the diagnosis of hypertension. And of those patients who are already on treatment for hypertension, nearly 50% do not have adequate control. So we have an issue in diagnosing and managing hypertension. Traditionally, we have been using office blood pressure as the tool to diagnose and manage hypertension. That's because that is the most used method and also often the only method available in large number of hospitals and regions. So, and it is also the most well-studied method with the strongest evidence. Therefore, has traditionally been used to classify hypertension, recommend threshold for treatment initiation, and to define treatment targets. There are many advantages in office blood pressure. It is readily available in most healthcare settings. There is strong data linking office blood pressure with cardiovascular disease. But the limitations are also there. We can easily overestimate blood pressure because it's properly standardized, and there is inadequate reproducibility. We can also miss the white coat hypertension and masked hypertension. Office blood pressure alone may not be correct in diagnosing hypertension. It can actually be misleading because if we look at this 24-hour ambulatory blood pressure recording, we can see that there is a white coat window during the first few of 1 hour. And then during the daytime, we see that the blood pressure is varying based on the patient's activities and the environment. We generally see a drop in blood pressure during night, that is called the nocturnal dip, followed by an early morning surge. So the blood pressure varies throughout the day. And what we want to know is the average of this blood pressure. And we are trying to do that by measuring the blood pressure at any given point in time. So there is an inherent fault in office blood pressure measurement when we try to know the average blood pressure of a patient. There are also difficulties in doing in the sense of measuring the office blood pressure in a short consultation. In countries like us, Sri Lanka and most of the developing countries, the doctor-patient consultation is very short. It lasts only about 5 to 10 minutes. And we have to do the blood pressure measurement within that time. And the time that we can allocate for blood pressure measurement is very short. Norman Kaplan said, the measurement of blood pressure is the clinical procedure of the greatest importance that is performed in the sloppiest manner. So how are we supposed to do it correctly? We have to choose the correct device, which should be validated according to the standard conditions and protocols. And also, we can either use an auscultatory or an oscillometry device with semi-automatic or automatic. The cups also come in different sizes, small, usual, and large, and we have to choose the most appropriate one based on the mid-arm circumference. There are certain conditions that have to be met. The room should be quiet with comfortable temperature. The patient shouldn't have smoked, used caffeine, food, or exercise within 30 minutes prior to measurement, and should remain seated for up to 5 minutes. There should not be any talking by the patient during or after, during and in between measurements. This is again very difficult in our setting. We usually take history while the blood pressure is measured. The patient should be seated with a supported back, legs uncrossed, feet unclosed. The bare arm should rest on the table with mid-arm at heart level. We should ideally take 3 blood pressure readings. If the first 2 are normal, then that is enough. If not, we have to take 3 readings with 1 minute interval between the readings. And we usually ignore the first reading and take the average of the last two readings. There are, however, instances where we may have to take more than three additional measurements. That is when the first two readings show a blood pressure difference of more than 10, or if the blood pressure is unstable, like in patients with arrhythmia. Atrial fibrillation is known to cause unstable blood pressures, and what is recommended is that we measure the pressure using manual auscultatory methods in patients with atrial fibrillation. And blood pressure measurement should also include recording the heart rate, which has prognostic value and cardiovascular risk when the resting heart rate is increased. The issue with recording the office blood pressure in a proper way is that it will take at least 7 to 8 minutes, sometimes more. So people have thought about reducing that time, and one of the poster presented in American Heart Association in September 29, 2021 showed that the 30-second gap between the measurement is as accurate as waiting for 60 seconds. So we might be able to save 1 or 2 minutes if that is agreed. We are also supposed to measure the interarm blood pressure difference in the initial visit at least. And if the difference is more than 10, it should be confirmed by repeated measurements, and the arm with a higher blood pressure should be used. If there is consistent blood pressure difference of more than 20 millimeter Hg, then we need to investigate for arterial disease. Diagnosis of hypertension based on office blood pressure should be over a period of weeks and with multiple office visits. We should have at least 2 to 3 visits over a period of 1 to 4 weeks. That can depend on the blood pressure and the cardiovascular risk. If the blood pressure is high, we may have to reduce the number of visits and the gap. Whereas if the blood pressure is on the lower range, grade 1, we can have more number of visits over a period of weeks to months. So it is based on multiple reading and not a single reading. However, if the blood pressure is very high, that is more than 180 by 110, and there is evidence of target organ damage or cardiovascular disease, then a diagnosis of hypertension can be made even with a single office visit. There is always the targets for defining hypertension has been changing over a period of time. And also there is a difference between the American colleges and the European colleges. What is agreed by most of the American colleges is a target of more than 130 by 80 as a diagnosis of hypertension, whereas the Europeans still stick with 140 by 90. There is also differences in the normal elevated blood pressures and what is optimal and what is high normal. Then hypertension stages also. There are stage 1, stage 2 in American guidelines, and the Europeans have 1, 2, and 3. So there is some discrepancy between the definition, but it has been there for some time. So is office blood pressure enough to diagnose hypertension? Even with carefully taken office blood pressure, about 15 to 25% of individuals attending hypertension clinics will have white coat hypertension, and about 10 to 20% will have masked hypertension. So office blood pressure measurements may not reflect the true blood pressure in nearly 25 to 45% of patients. As you can see in this table, the white coat hypertension is where the home or the ambulatory blood pressure is low or normal, but the office blood pressure is high. The reverse is what is called the masked hypertension, where the home or the ambulatory blood pressure is high and the office blood pressure is low. If both are low, then we would call them normal or normotensive, and if both are high, we can diagnose sustained hypertension. So it is this group of patients, the white coat hypertension and the masked hypertension, we will not be able to detect in a routine office blood pressure measurement. And that is a significant portion of those patients, about nearly 45% of patients. And that can vary actually. In older population, if we are screening, the white coat hypertension can be even higher, and we may be missing a large number of patients or over-diagnosing them as hypertension. One way of minimizing this is using unattended automated office blood pressure measurements. Here again, we use the same environment, but an automated device without people, without talking. It reduces the white coat effect, but does not eliminate. And it typically gives lower values than the usual office blood pressure measurements, which are similar to daytime ambulatory blood pressure readings. The feasibility in clinical practice has been questioned, but I think one advantage is that the doctor doesn't have to spend time with the patient if there are adequately trained staff to do this. So we can actually reduce the doctor-patient contact time. So we need to confirm the office blood pressure by doing out-of-office blood pressure measurements. As we saw, a large number of patients can be missed or overdiagnosed, and therefore we have to routinely follow in most patients with out-of-office blood pressure measurements. It should be confirmed by home blood pressure monitoring or ambulatory blood pressure monitoring. Office blood pressure levels with grade 1 hypertension rate, that is 140 to 160, and a diastole of 90 to 100, they are having increased probability of white coat hypertension. And in those with high normal office blood pressure, that is systole 130 to 140 and diastole 85 to 90, they have increased probability of masked hypertension. So if it is not possible to perform this home blood pressure monitoring or ambulatory blood pressure monitoring, then the confirmation of diagnosis has to be done by repeated office blood pressure measurements. So when we add the high normal and the grade 1, we are left with a systolic blood pressure range of 130 to 160 and a diastolic blood pressure range of 85 to 100, where we need out-of-office blood pressure evaluation for confirmation of diagnosis of hypertension. White coat hypertension, as we saw, is where there is elevated office blood pressure with a normal awake period ambulatory blood pressure reading or home blood pressure reading. Thomas Pickering is the person who coined the term white coat hypertension. It occurs more frequently in women, older adults, and non-smokers. It is not a clinically harmless condition. Progression to sustained hypertension has been found. It is actually 2.5-fold higher than the normotensives, and there is also increased cardiovascular risk compared to normotensives. Masked hypertension is actually the opposite. It is suspected when young individuals with normal blood pressure in the office, but who have elevated out-of-office blood pressure. Here, the risk of cardiovascular death and morbidity is even higher than white coat hypertension. The patients who have at risk of masked hypertension are younger people, men, and smokers, unlike the white coat hypertension, where it was more common with elderly people, females, and non-smokers. Masked hypertension is also common in patients with people with higher physical activity, increased alcohol consumption, anxiety, job stress, obesity, diabetes, CKD, and family history of hypertension. Again, masked hypertension is associated with a higher risk of developing sustained hypertension. So, out-of-office blood pressure evaluation is either ambulatory blood pressure reading or home blood pressure monitoring. Both provide larger number of blood pressure measurements in conditions that are more representative of daily life. So there are two advantages. One is we are getting larger number of blood pressure reading, so the average of which is more likely to represent the true blood pressure of the patient. And these are measured in a condition where it is more representative of the patient's life than an artificial condition. The indications for ambulatory blood pressure reading are to diagnose hypertension, to detect white coat hypertension and masked hypertension, to diagnose nocturnal hypertension, and non-depress. Instructions have to be very carefully given to get a good reading of ambulatory blood pressure monitoring. We have to explain it, ask the person to follow the daily activities, advise the patient to remain still with arm relaxed at each measurement. And they are generally asked not to drive. And very important is to give them a form to record the sleeping times, drug intake, any symptoms or problems during the recording. These are very important if you have to get a good reading. It generally takes about 10 to 15 minutes to initialize the device, and usually we let the monitor measure the pressure every 20-30 minutes during the day and night. Again, the cuff size is very important. We need at least 20 valid awake readings and at least 7 sleep blood pressure recordings for the report to be of value. If we don't get it, then we may have to repeat it. It may not be suitable for patients with AF because these devices are not validated to measure blood pressure in atrial fibrillation, and patients with thrombocytopenia may develop bruises because of repeated blood pressure measurements. So we have to be careful about that. Interpretation is fairly straightforward. If the average 24-hour blood pressure reading is more than 130 systole, 80 diastole, then we diagnose hypertension. For daytime average, it is generally the cutoff is 135 by 85, and nighttime it is 120 by 70. And if we see a drop in blood pressure during night compared to daytime, then those patients are called dippers. Though it's a normal way, it's a Gaussian curve, we arbitrarily have put 10% as the cutoff. So anyone who has a drop of more than 10% is considered as is a dipper, and anyone who doesn't have or who has less than 10% drop is called a non-dipper. So, in summary, the ambulatory blood pressure reading gives multiple readings done in a usual environment during routine daily activities as well as during nighttime. And that is the only study, at least at now, which gives nighttime blood pressure readings. It is very well studied, there is a lot of evidence to it, and we can identify white coat hypertension and MAST hypertension. Most guidelines recommend ambulatory blood pressure reading as the gold standard for diagnosing hypertension. But they say there is no place like home to diagnose hypertension. That is from the BP check study, which found that patient-centered perspective, BP monitoring is the most acceptable method. Home BP monitoring is the most acceptable method for diagnosing hypertension. So from the patient perspective, what is preferred is the home blood pressure monitoring over ambulatory blood pressure monitoring. It is reliable, home blood pressure monitoring, it is convenient and less costly. Again, for accuracy and reliability, we have to use a validated device, standardized procedures, and good patient information and training is essential. The key parameters that we measure are the morning blood pressure and the evening blood pressure. It is widely used and it is being increasingly used compared to a few years back because the devices are freely available and at low cost. It can identify both white coat hypertension and MAST hypertension. The indication is to diagnose and confirm the diagnosis of hypertension and also to detect white coat hypertension and MAST hypertension. Again, we have to be very careful. The device should be validated, should use an upper arm cuff oscillometric method, appropriately sized cuff, and there are now machines which can automatically store. And some of these devices are equipped with telehealth, which can transmit the readings to the healthcare providers. How do we do this? Again, the conditions are the same. The patient should be in a quiet, comfortable room without smoking, caffeine, or food, as in the office blood pressure. Remain seated, no talking. The posture is almost the same. The cuff should be appropriately sized. We take 2 measurements, one in the morning within 1 hour of waking after urination, before breakfast, and drug intake before the drugs are taken, and evening before going to bed. We have to have at least 2 readings with a 1-minute interval, twice daily for a minimum of 3 days, but preferably 7 days. We usually discuss the first day reading and calculate the average of all the other readings. Individual readings don't have much diagnostic accuracy, but if the average is more than 135 by 85, it indicates hypertension. These are the guidelines that recommend home blood pressure monitoring, and most agree on a cutoff of 135 by 85, except the American Heart Association guidelines, which still say the cutoff is 130 by 80. Do we have enough evidence? Yes, there are a large number of trials that have been performed, And they have found that the home blood pressure is an important predictor of target organ damage, cardiovascular disease, stroke-related morbidity and mortality. And in fact, it provides better prognostic information than office blood pressure. If we have to compare the ambulatory blood pressure monitoring and the home blood pressure monitoring, we will see that both can identify white coat hypertension and mast hypertension. But the ambulatory blood pressure monitoring has stronger prognostic evidence. It is the only reading that gives nighttime values. Measurement happens in real life settings while the patient is walking, working, things like that. And we can identify additional prognostic blood pressure phenotypes. There is abundant information given from a single measurement. The disadvantages are mainly it is expensive, sometimes limited availability, especially in a developing third world country like ours, and it can be uncomfortable to patients. Home blood pressure monitoring, on the other hand, is cheap and widely available. Measurement in a home setting, which may be more or less than the office. Patient engagement in blood pressure measurement is considered a very important factor, especially for patients who are already on antihypertensive treatment. It is supposed to increase their compliance, drug compliance. And it is easily repeated, used over a longer period of time to assess day-to-day blood pressure variability. But the disadvantages are that it is only static blood pressure is available, and there is potential for measurement error, and we don't get nocturnal readings, at least as of now. What is this additional information that we can get from out-of-office blood pressure other than confirming hypertension? We can get enough information about blood pressure variability. Blood pressure variability is being increasingly studied and has been of interest for research. There is short-term blood pressure variability within 24 hours, within a day. There can be day-to-day blood pressure variability and visit-to-visit blood pressure variability, long-term. These are supposed to be due to complex interaction between the cardiovascular regulatory mechanisms and external environmental and behavioral factors. The variability in blood pressure is supposed to be predictive of both stroke and cardiovascular events. They also predict the occurrence of fatal and non-fatal cardiovascular events, as well as total mortality. They can also predict hypertensive organ damage. There is a study which is called the JHOP study, which found that short-term BP variability was significantly associated with cardiovascular risk, independently of home systolic blood pressure. The risk increasing as variability increased. But we have to remember that blood pressure variability still remains a research topic. We don't really have any application in daily clinical practice. Morning home blood pressure is another important finding that we have to concentrate on, that is prior to taking antihypertensive drug. Even when the office blood pressure is normal, patients with high morning systolic blood pressure have a high risk of cardiovascular events, especially so if the systolic blood pressure is more than 155. It has shown to increase the risk of developing coronary artery disease 6-fold. That is almost double the office blood pressure of systolic blood pressure of more than 160. They have better reproducibility than ambulatory blood pressure measurements and stronger correlation with vascular function. So morning blood pressure prior to taking antihypertensive drug is a very important thing to monitor, even on patients who are on medications. Nighttime home blood pressure is another important factor. As we saw, that we can divide them into dippers and non-dippers. There are a large number of reasons why some of the patients don't show a drop in nighttime blood pressure. Sleep disturbance, obstructive sleep apnea, obesity, autonomic dysfunction, CKD, diabetic nephropathy, neuropathy are all thought to be the causes. And also, there is a concept of nocturnal hypertension. That is, when we do the ambulatory blood pressure, we find that the daytime blood pressure is within normal, that is less than 135/85, but the nocturnal pressure is more than 120/70. So they are supposed to have nocturnal hypertension. And that also has some prognostic value in terms of developing cardiovascular risk and cardiovascular mortality. If we look at clinical utility of office and out-of-office blood pressure measurement, we can see that for screening purposes, office blood pressure is the most suitable. But For confirmation of diagnosis, ambulatory blood pressure, 24-hour ambulatory blood pressure is the ideal, though home blood pressure also is reasonable second option. But for follow-up of patients, to make sure that these patients are well controlled, the most suitable is the home blood pressure monitoring. So in a screening, if you find a blood pressure which is optimal, less than 120/80, what is recommended is that we repeat the blood pressure at least every 5 years to make sure that they don't progress to hypertension. But the risk of developing hypertension is low, thus the interval is 5 years. But if they have normal blood pressure, this is according to the European guidelines, 120 to 30 systole and 80 to 85 diastole, we should monitor them more closely, that is every 3 years. But if they have high normal blood pressure, that is systole of 130 to 140 and diastole of 85 to 90, then we have to think of masked hypertension. And an out-of-office blood pressure measurement is indicated, especially so if they have the risk factors of masked hypertension, which we already saw. And also, even if the out-of-office blood pressure is normal, blood pressure should be monitored at least annually. For all other patients with hypertension, that is more than 140/90, you have to either confirm the diagnosis by out-of-office blood pressure measurement, which is the preferred, and where it is not feasible or practical, we have to do repeated visits of office blood pressure measurement. This is slightly different. This is what the Americans recommend. That is, again, you can see patient with elevated screening office blood pressure of more than 130/80, that is their cutoff. If they have severe hypertensive emergency or severe hypertension that is more than 180/120, that is enough to diagnose hypertension. But on those who have less than that, but who have blood pressure of more than 160 systole and more than 100 diastole, if there is hypertension-related target organ damage, if there is ischemic heart disease, heart failure, LVH, cardiovascular disease, then that is also enough to diagnose hypertension. If the blood pressure is less than 160/100, or if they have more than 160/100, but without any of these, then the patient is asked for to perform home blood pressure monitoring. So home blood pressure monitoring is preferred over ambulatory blood pressure monitoring. And if the home blood pressure monitoring shows an average blood pressure of 130/80, again note that this is American. For all the other guidelines suggest 135/85, then hypertension is diagnosed. If not, we have to consider white coat hypertension and perform ambulatory blood pressure monitoring. Or if the person cannot do home blood pressure monitoring, then again proceed with ambulatory blood pressure monitoring. If the ambulatory blood pressure monitoring shows high values, then hypertension is diagnosed. If it is not, then white coat hypertension is diagnosed. If ambulatory blood pressure monitoring is not possible, then we have to rely on repeated office blood pressure measurement over a period of weeks, at least 3 readings, and see whether we can get the average blood pressure. If the average blood pressure is still high, we have to diagnose hypertension. What is the future? Future is, it looks as if home blood pressure monitoring will be the future, but with additional facilities. Telemonitoring to control blood pressure when close contact is difficult. There will be wearable devices for cuffless and non-invasive beat-by-beat monitoring of blood pressure. These future devices will be able to generate information for artificial intelligence strategies, and there will be devices with the ability to monitor temperature and environment conditions, even detect arrhythmia so that we can interpret the blood pressure readings more accurately. So in general, we have to use any 2 of the 3 methods, that is office, home, or ambulatory, which agree are necessary for a reliable diagnosis. So 2 out of the 3 should agree to make a reliable diagnosis of hypertension. It can be office and home, office and ambulatory. In most patients, blood pressure should be evaluated in the office and with ambulatory blood pressure monitoring or home blood pressure monitoring. When office and out-of-office measurements agree on the hypertension and classification, a diagnosis can be safely made. When they disagree, as that happens in white coat hypertension and masked hypertension, confirmation with repeated office and out-of-office measurement is necessary. And the decision should be based on out-of-office measurement, that is ambulatory or home blood pressure monitoring. Ideally, we should use both ambulatory blood pressure and home blood pressure because they occasionally provide different and complementary information. Thank you.
Thank you, Dr. Gurubaran, for that very informative presentation on evaluation of a patient with high office blood pressure reading. I think in the interest of time, we'll skip the questions and keep them for the end of the session. And let me introduce the next speaker.